So for those who are reluctant to move forward with the biopsy, we can resolve that concern by offering them this cryo-assisted biopsy. The main concern is that there might be dislodgement of cells along the needle tract. The displacement can also be managed by ablating the needle tract. So we basically freeze a tumor, and then once that's done, we then pull the probe back for several centimeters and freeze the tract so that that displacement can be addressed as well.
Hey gang, so today I'm interviewing Dr. Dennis Holmes. Dr. Holmes is an internationally renowned breast cancer surgeon, educator, and cancer researcher specializing in the management of breast cancer. He's the medical director of Sam and Grace Carvajal Comprehensive Breast Center at Adventist Health Glendale in Los Angeles. And he's board certified fellow of the American College of Surgeons. He served as department head of several academic breast cancer programs and program director of 2 breast surgery fellowship programs. He's played a pivotal role in several breast cancer treatment innovations, including intraoperative radiotherapy, oncoplastic surgery, and cryoablation. And that's really what I am excited to talk with Dr. Holmes about, is cryoablation, to sort of bring this information to you and to the public, because a lot of people don't know about it. And I think it's an innovative option that I think is growing in its use, and the public needs to know about it. So, Dr. Holmes, thanks for taking the time.
Hey, it's a pleasure to be here, and thank you for the opportunity to talk about cryoablation. Really welcome it.
Yeah. So, what is it? What is cryoablation?
Well, put very simply, cryoablation is tumor freezing. Cryo means cold or killing with cold temperatures, and ablation is killing. And so we basically use a very cold temperature mediated by liquid nitrogen, for example. It's something that people are generally familiar with, to chill a tumor down to a temperature that it dies. We basically insert a needle into the breast. The liquid nitrogen flows through the needle. It chills the tissue surrounding the end of the needle. And using this, office-based procedure performed in a local anesthetic, we can treat a tumor just as we would treat a tumor in surgery. We ablate the tumor, we ablate the margin, and with that approach, we can replace surgery with cryoablation for many patients presenting with early-stage breast cancer.
And so early stage, that would be stage 1 and 2?
Ideally. The current technology for cryoablation is best suited for women with tumors 2 centimeters or smaller, although we do have the ability to treat larger tumors. Typically, if you have a tumor exceeding 2 centimeters, then we use more than one ablation treatment to treat the tumor as opposed to a single ablation treatment to treat a smaller tumor.
Are there multiple needle insertion points?
So it's a great question. So if you have a small tumor, meaning a stage 1 tumor, 2 centimeters or less, then we basically insert the cryoprobe through the center of the tumor, and it's able to ablate the tumor and a surrounding margin. And that's a single probe with a single insertion. However, if you have a larger tumor, say a 3 centimeter tumor, which doesn't quite fit well into a cryoablation zone because it won't have adequate margins, we'll use 2 insertions, one next to the other. And so you basically have 2 overlapping circles that would allow you to treat a larger tumor with adequate margins. For the most part, if you imagine sort of the size of an egg, we freeze the diameter of an egg, with the goal of having the tumor be about the size of the yolk. So that allows us to have a margin around the tumor to address the possibility that the tumor might be slightly larger than it looks, or that there might be other tumor foci around the edges of the main tumor. We want to make sure we have an adequate margin. So generally speaking, a single ablation will freeze and ablate a diameter of 4 by 3 by 3 centimeters. So the tumor has to fit well within that and have a margin for it to be well treated with a single ablation.
What's the recovery like? What happens after that treatment? Is there inflammation and swelling and some pain?
Yes, for most patients, it's very similar to the needle biopsy that they have to diagnose their cancer. It's a procedure, again, that's performed in a local anesthetic. Patients drive themselves to the office. They drive themselves home. We simply require that they wear a sports bra or snug-fitting bra to hold pressure on the area. There's usually swelling. There's usually bruising. Most of the bruising is gone by 10 days. The swelling is also generally gone by 10 days, although for larger ablations, it might take a bit longer. But really, I empower patients to go back to their normal activities the day after the procedure. We just ask them to avoid any sports for a 2-week period. But beyond that, they can use their arms in a normal way.
Is there currently any published studies comparing recurrence rates of cryoablation to surgical excision?
So there are a number of studies looking at the effectiveness of cryoablation. As of yet, we don't have studies that consist of a head-to-head comparison of lumpectomy to cryoablation. However, the studies that look at cryoablation do compare the results to similar patients treated with lumpectomy in other trials.
Mm-hmm.
So, for example, one published study, which is called the ICE3 trial, looked at cryoablation given to women above the age of 60 with tumors that were 1.5 centimeters or smaller. These are ER-positive tumors, node-negative tumors. And it found that at 5 years of follow-up, there was a 3% recurrence rate in the breast. Now, it's important to understand that amongst these cryoablation patients, relatively few patients had radiation. I think only about 14% of patients had radiation, and very few patients had lymph node surgery. I think only about 7% of patients had lymph node surgery. So they basically had cryoablation and anti-estrogen medication because these are ER-positive tumors, and no radiation for the most part. And yet it showed a local recurrence rate as low as 3% in 5 years. There have been a number of lumpectomy studies looking at omitting radiation for women that had small tumors treated with anti-estrogen therapy. And those studies also showed a recurrence rate of about 3% at 5 years. So we're basically showing that you can, replace surgery with cryoablation for these patients, add anti-estrogen therapy, and get the same result over 5 years.
Has it been used on any other types of breast cancer? Are there studies on, let's say triple negative or some that are not estrogen receptor positive?
Right. The studies that have been done, and I mentioned, let me just add that I mentioned the one published study. That's the one I just described, the ICE3 trial. I also conducted a separate trial called the FROST trial, which is to be presented later this year and published later this year. It's going to be presented first at a national meeting and then published. And it showed the same local recurrence rate, approximately 3% for this study over about 7 years. So again, we get this confirmation that selecting the right patients, particularly those with I would say selecting the ideal patient, those with ER-positive disease that can be managed with anti-estrogen therapy and providing them ablation allows you to achieve relatively low recurrence rates. Now, with any new innovation, we tend to start off very conservatively. We take kind of the lowest hanging fruit, the patients with the smallest tumors, the most favorable tumors. But as you well know, there are many women who don't meet those criteria that have larger tumors or have triple negative tumors or HER2 positive tumors, and some of them, refuse to have surgery. And so, although there have not been any studies looking at those patients, many of us, and particularly in my own practice, I've treated such patients for many years. It's not really an issue of whether or not ablation works. It's whether or not they have a sufficiently high enough risk of recurrence in the lymph nodes or in the breast or elsewhere that they need other therapies to manage those risks. Whether someone has a cryoablation or surgery, a 1 centimeter tumor can be managed with either of those approaches. There's nothing magical about a triple negative or HER2 positive. It's a 1 centimeter or 2 centimeters in size. You can remove it with lumpectomy. You can also ablate it. But we have to take additional measures to manage the risk of recurrence in the axilla or the risk of systemic recurrence in the lung or elsewhere.
So it sounds like the 5-year recurrence rate is basically the same as a lumpectomy. What would be the advantage of having cryoablation?
Well, for most women who opt for it, they're looking to have a procedure performed that minimizes the burden of treatment. They want a procedure that's convenient. They want a procedure that generally does not require, significant downtime. They want to avoid general anesthesia. This is performed in a local anesthetic. Many women are looking for sort of an alternative way, something that is more aligns with their value system about how they want to be managed. And so many of the patients that come from kind of the naturopathic community who are looking for non-Western solution. This is a Western solution, but it bridges, the treatment options. And for the most part, I mean, as with other innovations, my goal and the goal of many women is to do what is necessary, but not more than what is necessary to manage a cancer diagnosis. And if cryoablation works as well as lumpectomy, then it doesn't make sense that you should offer lumpectomy as a standard and a requirement for everyone presenting with a similar cancer.
I think there's probably a significant percentage of women with breast cancer that are afraid that surgery would promote metastasis. Do you have any thoughts on that, cryoablation versus surgery? And to me, it seems like it really just is about getting clear margins, but is there more? Could there be more to it?
I've looked at sort of the data. I see many people coming to me with that concern, and I've looked at the data, and my analysis is that it probably doesn't make a large difference, meaning whether you do surgery or cryoablation. It likely has more to do with how quickly someone gets to some treatment, because obviously the longer tumor remains in the breast, the more opportunities it has to spread, whether you do cryoablation or surgery. But I am sensitive to that concern. And so when I discuss it, I do observe some potential advantages of cryoablation over lumpectomy surgery. Now, I must confess that I use the same techniques in my lumpectomy surgery because I'm concerned about this risk. But one of the techniques that we do with cryoablation is we typically will inject a local anesthetic mixture around the tumor. The local anesthetic solution contains epinephrine. And so epinephrine causes the blood vessels to constrict. And so while the tumor is being manipulated, either with cryoablation or with surgery, at least there's not a free flow of blood into and out of the tumor that could facilitate dislodging of cells and potential metastasis. When with the area stabilized as such, when we insert a cryoprobe, we freeze everything in place. So, there's very little opportunity for things to move because, number one, as I said, we've controlled the flow into and out of the tumor, and we freeze it in place with the cryoprobe. And by the end of the procedure, the tumor is dead. So I think that there are some, logistical advantages that you have with cryoablation. You can extend some of them to surgery, but the fact that you can stabilize it and immediately kill it is an advantage. When we do surgery, there's a lot of manipulation of the tissue, there's retraction, there's pulling, and so there is a little bit more handling and disturbance of the tumor that's involved with the surgical approach as opposed to the cryoablation approach. But that said, I'm a surgeon, so I still do surgery, and I don't discourage patients from having surgery because I still think it works and we can manage many of the risks. But for those that are just so anxious about the possibility of metastasis that they would rather avoid surgery, we have another solution.
What about other tumor types? Are there practitioners using cryoablation for, ovarian or lung or stomach?
Right. There's quite a bit of interest in the use of cryoablation and in fact, a bit of experience with other sites. Obviously, for many years, we've used cryoablation to treat cervical dysplasia, which is, treating premalignant cancer involving the cervix that many women have experienced over the last few decades. There's a fair amount of experience using cryoablation to treat prostate cancer as an alternative to surgical resection of the prostate. We use cryoablation to treat kidney tumors. That's quite commonly done. And of course, for the metastasis, like liver metastasis, it has been used for treating it, although there are better technologies for that now. That's pretty much the experience in the U.S. But abroad, in China, they also treat other sites, for example, lung and other organs that we haven't quite developed the experience to treat here.
How widespread is this technology in terms of in the U.S.? Is it available in every city, or is it still kind of hard to get access to?
It's coming along. It probably isn't even. I'm sure it's not available even in every state. There's a limited number of performers, surgeons and radiologists who perform the procedure. That number is growing, but it's primarily been limited to the participants in these clinical trials that I've mentioned. I would say there's probably 20 active practitioners in the U.S. now. When the trials have been enrolling, there have been others participating in the trial, but they have not participated once the trial concluded. One of the limiting factors is that it's not been FDA approved yet, so that limits the ability for people to offer it, to get reimbursed for it. So that's been definitely a barrier to its growth, but that's changing. The FDA has considered, this technology quite recently. They haven't made a decision about it, but the recommendation was for the FDA to approve it. We're still waiting a decision, but the prospects are looking up, and once that barrier is overcome, quite likely it become much more available around the country.
So what's the difference in cost? Is there any difference in cost between cryoablation and, let's say, a lumpectomy?
Well, the main difference at this point is that lumpectomy is covered by insurance and cryoablation isn't, but I think very soon cryoablation will also be covered when the FDA approves it. But the main difference you should understand is that cryoablation is an office-based procedure that usually costs about $10,000 to perform. But there's no anesthesia cost, there's no pathology cost, there's no hospitalization cost like you have with surgery. And so on balance, it's a much more economical procedure for patients and for the healthcare system. So when the FDA does approve it and it becomes more widely available as a procedure covered by insurance, we'll find that we're all saving a lot more money by offering patients cryoablation as opposed to surgery.
Yeah, and dollar for dollar, how much would a surgery cost if it wasn't covered by insurance and someone was paying out of pocket? What would
The
that look?
real costs range between $20,000 and $30,000. That is including the hospitalization, anesthesia, pathology costs as well.
Yeah, so that's a big difference, folks. I mean, half to a third of the price.
Yes.
I mean, definitely good for healthcare and the insurance industry too.
Yes.
Is there a website where a person could go to do a search or find a directory of practitioners?
I'm not aware of such a website at this point in time. I have a website called cryoablation.com where I include information about sites that are participating in clinical trials, but there's no directory. And maybe for good or bad reasons, I would say that it's a technology that's relatively new. It's new to most patients, but it's also at a point where it will likely rapidly expand, and you'll get a wide variety of experience. You'll have providers that have been doing it for decades, and those that are doing it for the first or second time. So there needs to be some sort of way to vet the provider, because like most things in life, there's a significant learning curve. It's not the same as doing surgery. It's not the same as doing a biopsy, even if you're able to do a biopsy. They're unique considerations. So I would just say that such a website doesn't exist, but even if it did, it would require a kind of a curation, if you will. The second concern that I have, and this is, I'll express my bias, is that treating a cancer is more than simply sticking a needle into a tumor and freezing it. There's a pre-operative workup process, there's examination, there's follow-up, there's counseling patients about their benefits, risks, and alternatives. There's ordering additional tests, genetic testing, there's all these things that are normal standard operating procedures for surgeons, but that are not standard operating procedures for radiologists. And although radiologists are able to do cryoablation because they have the technical skills, that I sort of caution patients to make sure that they recognize the need for broader consideration. So if the radiologist is working with the surgeon or with the medical oncologist who takes on the responsibility of managing those concerns, that's fine. But if the radiologist is simply doing it because they want to do it and maybe there's some financial benefit, then it's a disservice if they do not guarantee or ensure that the patient has a multidisciplinary assessment and management of her cancer, which is the standard procedure. So
Comprehensive care.
Comprehensive, right? So
Yeah.
I'm a surgeon. I'm certainly biased, but I'm biased because there is a standard for how we manage patients with a cancer diagnosis. Is not simply taking the surgery without consideration of the things that should precede it or should follow it.
Now, you mentioned something earlier about anesthesia. Is it standard procedure for lumpectomies for the patient to be unconscious?
It is standard. It is not required in many instances,
Okay.
but it's standard. The considerations have more to do with the depth of the tumor, the size of the tumor, the fact that most patients that go to surgery will have breast surgery. They are also likely to have lymph node surgery, so they have two surgical sites. And so because of the sort of complexity and the potential for patient discomfort, it's just easier to have the patient asleep and unconscious, either with general anesthesia or sedation, like a twilight anesthesia. With cryoablation, it's a fully alert and awake procedure. It's performed just as a needle biopsy is performed under ultrasound guidance. We inject local anesthetic, and within a few minutes, the area is anesthetized, and then we can proceed with the procedure. In addition, freezing or chilling, as you know, is pain relieving. So, unlike some ablation techniques where heat is involved, ablation techniques where there's chilling actually is a pain relieving procedure, which makes it easier to perform that procedure in an awake patient in the office setting.
And what if there's lymph node involvement? Is that like a disqualifier and just for a cryoablation, and just that you just put him in the surgery on the surgery path?
So I think personally that when there are lymph nodes involved, the better management option is to remove the lymph nodes surgically. I certainly see patients that are not willing to have that performed, and so it's possible to perform ablation of lymph nodes that are abnormal as well. And we do that quite regularly for patients that are unwilling to have surgery. The reason I think there's a slight advantage of surgery over the lymph over cryoablation in this case is that, when we're performing surgery, we have the ability to have a tactile, tool, our fingertip, to feel around the axilla. So even though there might be one obvious node that we can detect by ultrasound and maybe target with cryoablation, in surgery, we can feel around, and sometimes we find smaller nodes that aren't big enough to show up on by ultrasound, but those nodes are positive. And so we can actually perform a better procedure. There's a second factor that's important to consider, which is that, lymph nodes can be fairly high up in the axilla, or they can be kind of lower in the axilla, like closer to the breast. If they're closer to the breast, they're kind of in a safer area that might be more amenable to ablation. But the higher up they go, the more collateral damage can be performed, can occur related to injury of adjacent blood vessels or nerves or lymphatics. And so, particularly when the nodes are up high, I think there's a definite advantage to performing the procedure surgically, because we can, push aside things we want to avoid and target the abnormal node. We can't do that with cryoablation. So I generally say if it's just one or two nodes and they're low-lying nodes, then cryoablation becomes an option. If it's anything else, surgery is better.
Yeah, and also, when you have it open, you can see things that you wouldn't necessarily
see things you want to remove and see things you want to avoid.
Yeah. When I had surgery from colon cancer, it was assumed, because I didn't have a PET scan or CT before the surgery. And so it was assumed that I was, maybe stage 2. And when the surgeon went in laparoscopically, he observed lymph nodes that were involved. And then he opted to go ahead and just cut me open and, sort of go old school and so removed the tumor and surrounding lymph nodes. Right. And so, because he could see what was happening. So that's what made me think about that. This is really fascinating. And I think a lot of people will be interested in this option because it sounds like it's an easier option. The recovery is faster. I know a lot of people just don't like being cut open. They would, just prefer not to be, even if the risk is the same. I understand that psychologically. Is there anything else that we haven't covered that you want to share or talk about related to cryoablation that you think people would benefit from knowing?
Right. Thank you. There are two topics that I would like to mention. One has to do with sort of, the reluctance of some patients to move forward with generally recommended procedures. One is a needle biopsy procedure. Sometimes people are reluctant to have a needle biopsy because, you mentioned avoiding surgery because of the risk of tumor spread, but others are interested in avoiding a needle biopsy because of concern that itself might displace the tumor. And I recently published a paper, with these patients in mind, sort of trying to show them how we can also manage that risk with cryoablation. We can isolate the tumor. Instead of doing an ablation, we can do a biopsy of the tumor and ablate the needle tract. The main concern is that there might be dislodgement of cells along the needle tract that could
occur.
or displacement of it into the bloodstream. So with the local anesthetic, we can sort of manage that displacement into the bloodstream concern I mentioned, but the displacement into the needle tract can also be managed by ablating the needle tract. So we basically freeze a tumor, and then once that's done, we then pull the probe back for several centimeters, generally about 4 centimeters, up to the undersurface of the skin, and freeze the tract so that that displacement can be addressed as well. So for those who are reluctant to move forward with the biopsy, which is a problem if the tumors look suspicious, we can, resolve that concern by offering them this cryo-assisted biopsy procedure.
I think that's fantastic.
Right.
Yeah, that would be just, I think, sounds very valuable to be a standard procedure for every biopsy. You got my vote.
Thank you. And then the second thing is that much of the focus of cryoablation has been on the treatment of ultrasound visible tumors, stage 1. That's the requirement was stage 1 because these tumors are generally large enough to be seen by ultrasound, which enables you to perform an ultrasound-guided cryoablation procedure, for example. But stage 0 breast cancer was kind of skipped over. This is an earlier stage cancer, if you consider it that, or a pre-invasive lesion. It has less potential to cause long-term harm, yet we treat it the same way that we treat a stage 1 or stage 2 breast cancer. So clearly there was a need for some way to sort of deal with the problem, but not using the standard approach. And so I've also been conducting a clinical trial looking at the use of cryoablation for management of DCIS, ductal carcinoma in situ. And indeed, these cancers or pre-invasive lesions generally are not ultrasound visible. But what we're testing in this trial is the ability to place an ultrasound visible marker next to the site of DCIS or at the site of DCIS and use the marker as a target. So we're basically converting this patient with an ultrasound invisible tumor, DCIS, to an ultrasound visible tumor or target, and which allows us to offer them cryoablation as well. We're now doing a study in which patients undergo cryoablation. They undergo marker placement next to the DCIS, cryoablation, and then 6 months later, we do a repeat biopsy of that area with a needle to document whether or not we have indeed ablated the DCIS. And we've had just about perfect results so far in demonstrating that we can, offer patients with DCIS cryoablation if we prepare them appropriately by placement of an ultrasound visible marker.
I'm glad you brought that up. That sounds like a really great option for stage 0, because I know women that have had double mastectomies after a stage 0, which seems, that seems like, and I don't know if it was their choice necessarily, or if that's what was pushed to them by their doctor. There's probably cases of both, right? But that seems a little drastic for stage 0. And I really do. Yeah, I would be way more inclined to cryoablate it. Like, okay, yeah, just get in there and take care of it. It may turn into nothing, but that's such an easy procedure, it sounds like. I see a lot of potential with that,
And fortunately, there's a lot of interest now and attention on sort of taking less aggressive approaches to management of DCIS. We're getting more comfortable with sort of watchful waiting. But the one downside of watchful waiting is that it doesn't prevent progression.
Sure.
It just allows you to detect it earlier, but it doesn't stop the clock. And it also involves, continually having regular mammograms. It involves often taking anti-estrogen therapy without sort of a guarantee or assurance that things won't progress. So instead of sort of, although that's a valid approach, another approach is to simply deal with it, with an ablation procedure, and then the matter is put to rest. At least you won't have to worry about that site progressing, and then you can go back to routine follow-up and so forth.
That makes a lot of sense.
Yes.
Well, that's encouraging. Very encouraging for sure. I think I actually talk about stage 0, the stage 0 controversy in my book, because there are, it's not technically cancer yet. It could become cancer. It may not. A lot of women are scared into treatment or overdiagnosed and overtreated in that stage 0 realm. So this really does sound like a good option for them, and I hope it becomes widespread.
Well, there's a paper that's been submitted. It was accepted, so it'll be out later this summer. I'll share with you. This is the interim result of this DCS study. The long-term results will look at the local recurrence rate over time, but at least we're publishing interim results showing that we can actually, effectively ablate DCS just like we can effectively ablate invasive cancer.
That's great.
There's one other topic that I'd like to mention if time
Please.
permits. Thank you. So certainly we've spent most of the time today focusing on sort of patients with small, stage 1 and stage 0 tumors. But there are patients that have larger tumors that are still unwilling to have surgery or pre-operative chemotherapy or medications to downstage the tumor, who are only willing to consider a non-surgical approach. And so for such patients, it is possible still to offer them cryoablation, but this is not cryoablation with a single ablation. This is more like the multiple needle approach where you ablate a much larger area with these overlapping ablation zones so that we can encompass not just the tumor, but the surrounding margin. The analogy that I give is like, it's almost like looking at the Olympic rings, 5 overlapping rings, and we just shape the rings to encompass the tumor. So if the tumor is linear, we can stack the rings one next to the other. We can stack them, front and back, top to bottom, or in any orientation. We just have to determine, the volume and how many rings are needed to encompass that volume with the margin. And so it is possible to manage such patients if they're unwilling to have surgery. They're more challenging. Again, the learning curve and the ability to do such procedures is much greater. The learning curve is much greater, and the ability is more limited. But for those of us with experience, this is also a fairly routine practice. I would say that I've been at this at ablation for 20 years. I've been doing ablating cancer since 2009, so 15 years, and others are sort of coming on board, but because there are others on board to do kind of the small cancers, I find myself doing many more of the complex cancers, so that almost half of the patients I treat today require multiple ablations, not just one ablation. But that was, that came about from, almost 2 decades of experience learning sort of how to adapt the technology to optimize it for these more complex tumors. So it is possible. One shouldn't see surgery as the only option. Surgery might still be the better option, but it's not the only option for someone who's unwilling to have surgery.
Well, it's great that you're willing to work with patients on their own terms, and that you're willing to take on complex cases, because I understand a lot of doctors and surgeons, they don't want to. And so I'm glad you do. There are a lot of people in my audience that are very holistically minded and skeptical of conventional medicine, for good reasons. And so that's great. How can people connect with you? Obviously you are a professional doctor, so there may be people in my audience that want to work with you, want to consult with you for surgery or cryoablation. Are there different places we can send folks professionally? And then do you do much on social media in terms of education and sharing information like that?
Yes, I do quite a bit. I have a website, which is simply www.cryoablation.com, where they can find out a lot of information about the procedure, about me, about the clinical trials that are available, just basic information about cryoablation in general that's available there. And that's my main channel. I also occasionally, every other month, do a webinar where a patient, the topic varies, not just cryoablation related, but cryoablation comes up a lot, where a patient interviews me about, the breast cancer topic for that month. And so that's available on social media as well, primarily distributed through Facebook. But all of my social media handles are accessible through that cryoablation website. In addition, I have a practice for my primary practice. I have a website called www.dearholmesmd.com, which is my drholmesmd.com. It's my name and my primary practice. But for cryoablation, it's definitely www.cryoablation.com.
You were the first one to snag that domain. Congratulations.
Yes, yes, I was. But I've been doing it for over 2 decades, so I guess I was the first to the table.
Yeah, that's great. I love it, man. I love it. Well, Dr. Dennis Holmes, thank you so much for taking the time to talk with me and to share, your wisdom and expertise and insights with my audience.
Thank you.
I know you're going to get a lot of inquiries, and it might be a little overwhelming at first, but anyway, I'm excited about what you're doing. I know you're really helping a lot of people. And again, I just want to thank you for being the kind of doctor that will take on complex cases and work with people on their own terms. And, that really is so important and so needed today, because there's a lot of doctors that are very difficult to work with and very rigid and can be not very nice people. And so we want to celebrate the good ones.
Well, I do believe in patient-centered care. It's not just jargon in my practice. It does center the patient and trying to meet them where they are, to offer them treatment options that help them move forward with their treatment. Yeah.
And, just to add a little bit before we close, I'm optimistic with our current government and regulatory environment and strategy that maybe the right to try will be expanded, and that patients and doctors will be allowed to try therapies that are quote unquote not approved.
Mm-hmm.
I think medical freedom is so important, and we've had many decades of, in the US anyway, of a pretty tightly controlled medical environment with good intention, but also didn't allow doctors the confidence to work with the patient on their own terms.
Mm-hmm.
And so, for fear of losing their license or whatever.
Yes.
And so anyway, all that to say, I'm hopeful. I'm optimistic that we'll see some really nice improvements and broadening freedom in medicine, and ultimately, doctors will benefit, patients will benefit. We'll just have a better healthcare system.
Hear, hear.
Hear, hear. Well, thank you again. Thank you, Dr. Holmes. Thanks for watching, everybody. We got links for you. We'll put them in the show notes below the video, wherever you're watching. Cryoablation.com and drholmes.com are the two places you can connect with Dr. Holmes and learn from him and find out more about cryoablation.
drholmesmd.com.
Thank you for the correction. Dr. Holmes. We don't know where Dr. Holmes is going to take you. drholmesmd.com. Bye, everybody. We'll see you on the next one.
Thank you. Have a great day.